Okay, we're gonna get back together. If everybody could start making their way back in. Oh God. Well, they're not always. What's this button down here? Okay, can we have everybody start coming back in? I know we are enjoying our break, but we do want to try to get out of here on time. I did. So bad. I've eaten so horribly the last 3 days. But it was so good. Daniel, are people making their way back in? Are people coming? People making their way back in?
No, people are just getting coffee, waiting for someone to see.
Yes, that's my notes didn't pop up from my last talk.
That means that this SCCAPE slide doesn't have the updated version.
Notes in there? Yeah, I was freaking out.
Do you want to do it again?
That's my meter.
Yeah.
So what do I do to do it? So you gonna be there?
I'll come up and do it. Yeah.
Because it's the first thing I do.
The first thing. Okay.
So I want to do that before I tape.
One more minute. If everybody could start making their way back in, please.
Our stuff is big. We need to start on time.
People are slowly making their way in. This is not class. Did everybody get scanned in when they came in? I don't have, oh, Stephanie will. All right, anybody else need scanned? Well, Stephanie right over here. Stephanie. Okay, we're going to go ahead and get started so we can try to get out of here on time. I know it's been a really long day. Hopefully you all are still awake because now we're actually going to get into the community health worker roles and responsibilities. I know it's taken us a while to get here, but we felt that there was a reason why we did that. So you met my co-facilitator colleague Joan, who really without her, we would not have been able to put this together. And so I just want to tell you a little bit about her background. Joan is a retired nurse from the Virginia Department of Health, where she worked in several leadership roles in the Office of Family Health Services. She has a master's in nursing and is a retired women's health nurse practitioner from Virginia Commonwealth University. She has enjoyed an extensive career in acute care, teaching, and for the past 22 years in public health. As a program manager and director at VDH, she was responsible for all programs regarding women's health, maternal care, breast and cervical cancer screening, newborn screening including sickle cell disease screening, home visiting, nurse case management, family planning, and teen pregnancy prevention. She has published several articles and contributed to several nursing textbooks on topics regarding women's health, perinatal depression, and screening for substance use in pregnancy. During service at VDH, she was lead staff on the State Health Commissioner's Work Group on Infant Mortality and the Virginia Maternal Mortality Review Team. Since retirement, she has remained active by teaching community health nursing at Longwood University and developing a community health nurse course for Aspen University. She has been involved with the enhancing use of hydroxyurea in sickle cell disease using patient navigators since its inception, developing and implementing the patient navigator training curriculum. Please welcome Joan.
Thank you. We're going to do a Mentimeter. I do that. Whoop. Oh, I went backwards.
Just
Went that way. That way.
that way, if you're not comfortable.
Okay. All right.
All right?
Mm-hmm. I don't want to taint you. Okay, that's not the right one.
Yeah, it's kind of
Okay, good.
the one thing you got.
Okay. We've been talking about navigators, patient navigators, community health workers. Let's do a Mentimeter. What titles have you either worked with, heard of, or whatever? Let's see what we come up with on the cloud. What titles have you heard in your community? Okay. Interesting. Okay. Case manager. So if it's really tiny, that means it may only be one. Okay, looks like it's kind of slow. No, got a couple more. And you have to actually go out there.
Yeah.
Yeah, just for a minute. Just for a minute. I think has everybody had a chance to enter something? What have we discovered already? There are many names. Guess what? Since I've worked with the sickle cell program and been interested in this area, I started kind of capturing all the different titles and names that I was seeing in the literature and from my interactions. I'm up to 70. Okay? So now I want to do something else, and you can go on and get me back to slides. How many of you right now consider yourself a community health worker? Show of hands. All right. How many of you are navigators? All right. How many of you are patient navigators? Okay. How many of you are health educators? How many of you are care coordinators? How many of you are case managers? All right, this can go on all afternoon. Have I made my point? Several of you put your hands up more than once. All right, so, do I just hit? All right, That way. All right. Now let me explain my chart a little bit. Those of you that are going to stay over for Friday morning are going to hear a lot more detail about this. But from our experience with the R18 grant, and from us delving into the literature over these last few years, and I have to admit, you heard that I have a public health background. And I had worked with several programs that were using these lay health advisors, lay health advocates, peer mentors, whatever we want to call these folks, in maternal child programs, all right? And so what we've discovered is that, as you've discovered, there's all kinds of titles out there. So most people are very confused as to about what in the heck you are. Have you run into that? When you've gone and you say, well, I'm a patient navigator, or I'm a community health worker, and people kind of look at you like, well, what is that? So therefore, what we have learned from this over the last few years, that there's, as I said, there's over 70, and I think there's only 66 on here or something, because I've discovered a couple since I did the slides, all right? And so we have looked at this and said, you know, maybe there's like these 4 categories of folks out there. The term community health worker is like an umbrella term, and there's actually a community health worker movement across our country. And some of you are very aware, and you may be very involved. Are any of you part of the National Community Health Worker Association? Good, great. So you can come and tell me some stuff. I'd appreciate it, all right? So I call it a movement because it is like a movement. There's a wonderful new workforce out there that's popping up all over the country. And so I'm going to be sharing with you a little bit about how that's come about and where we are, because I think it's important as we look at how we want to move our programs forward as to what should we call these people. I don't have the definite answer, okay? But I'm hoping through some of the interaction with you folks and what I've been even learning the last day or so, that we can hone in on this a little bit. But from our experience, we've come up with what we call the first category as our peer community health worker. And this feeds into the discussion we just had earlier today. We need to look at that a little more carefully, and I think we can build on that. And those of you that are working in your community-based organizations, I think you could really be a wonderful partner for us to develop that. Then there's that other group that are folks that are not necessarily involved with an institution, like our program here at VCU, but work out of various more community-based groups and are usually not highly educated. And I don't mean that they don't have knowledge and skills and abilities, okay? I'm just saying they don't have those credentials stuck in their pocket, all right? And they, we think, are more of the general community health worker. And you'll see some of the terms here, which I think you probably have heard and seen and probably even worked with some of these folks. The HIV group really explored and developed this a lot using the HIV prevention coordinators and HIV mentors and all of that. Because I'm old enough, I remember the whole HIV scare of the 80s, okay? And so they used folks out there that were HIV positive to work with their community to get people in and get them tested, because we were losing good people dying of HIV because we didn't understand what in the heck was going on, all right? So that was a very successful movement. Some of you are from other parts of the country. There were the promotoras. We have groups out there that are very community-based. So we think they all kind of fit into that category. We may be wrong, and we'll take challenges, but this is what our proposal is. And then when we came about looking at our program, we really felt that it was more of a clinical community health worker. Because after all, our patient navigators, we call them, are institution-based. They're hired by a health organization, and they probably have to have some fairly significant credentials. Not necessarily that formal degree, but they had to have some credentials or something that we could hang our hat on. And then what we've discovered over this last couple years with our work in reaching out into the community is that I don't know whether, well, my buddy from Minnesota knows this. In some states and in some areas and across the nation, there's a movement to educate health navigators at the community college level. And that term they've already coined, and it's out there, and they have proposals and recommendations and standards of what a person should study and have. And it's like 60 credits of community coursework. I see my head over there nodding, okay. And we didn't really know that when we started. We had heard the term health navigator, but being that we were working with patients within the sickle cell catchment area that we were working with, we said, hey, they're patients, so we're calling them patient navigators. So that, does that kind of ring a bell with people? Because what's happening is that when you go to the literature to try to study this, oh my gosh, you don't know what to go look up. So therefore, when we went to the literature, we looked up just about all of these titles, okay? So I've been in the literature up to here and then some, because there is now when we first started our grant in 2012, I went to the literature and the list was about this big, all right? So we were flying by the seat of our pants, to be real honest, okay? But then over this last few years, things have really, and there were some things that were in the pipeline that popped out starting around, well, some things happened in 2010 that we had not found out about because they were in, what do you call it, the gray literature? I call it the renegade literature. It's published reports from, say, like states or groups, but they're not in the like PubMed, medical literature, all right? But then we found them, so I now know about them, like 2010, 2012. So therefore, this is just what we've kind of put together. It's just kind of our model that we're thinking, gee. So therefore, what in the world is this thing called a community health worker? Well, as you can see there, I've just listed a couple of very common terms. And as we've already discovered, there's many more, all right? Now, this is kind of the evolution of our thinking, and this builds on some of what we talked about earlier today. When we first were talking about the grant that we actually have just completed, the NIH research grant, our first thought, I think, or one of our first thoughts was, oh, let's work with community-based organizations and let's get some of our patients and let's have peers. That seemed reasonable, didn't it? And as we talked earlier today, there's some real positives in that. And we would like to explore that more. But I can tell you from being in a big institution, a bureaucracy like a VCU of the world, guess what? We ran into some walls. We got into issues of confidentiality, okay? We got into issues of, even though we're seeing, what is it, about 400 patients, 600, all right? Still, there's still a lot of the same patients that are coming and going and whatever, and trying to maintain confidentiality is like, ooh, did you run into that? Yeah. So then we got to thinking about, well, we've got some wonderful patient advocates out there that would probably be great at this, but if we hire them and then they get into some really not as healthy time, and our patients are going to need help pretty consistently. So how are we going to deal with that? All right? And then we got into some other issues of our institution about, well, you know what? You go out and hire from a state institution, you can't be discriminatory. So you got to be careful about that. So that's when we kind of went, And then the researcher in me, I go delve into the literature, and guess what? I had some very conflicting reports from the literature. Now, I heard earlier that some of you have had some positive experiences and good outcomes, but I hate to tell you, but in the literature, that's not necessarily the case. There have been questions raised, one particular in California working with diabetic patients, teaching diabetic patients. They actually had some issues with that. Now, the folks that are in the back injury, neuro, they've had some good reports where you have folks that have debilitating because of car accidents or they have brain surgery and they actually work with people. They had some pretty good reports. HIV folks had good reports. The program, any of you heard of Reach to Recovery? the breast cancer, where the ladies who've survived breast cancer go work with ladies who've just come out from having their surgery. Wonderful outcomes with having peers helping peers. But then there was some that had. So we this is our evolution. So then we got tacked onto this community health worker as this overall umbrella term. And then we moved to the subset of patient navigator, is what I just explained, because of being in our institution, et cetera. One particular thing, a big discussion group out there with community health workers, is whether these folks should be residents of the United States, citizens of the United States, and all about criminal background checks. Well, I can tell you for a fact, for us to hire somebody at a VCU, we're going to have to go through some of those little hoops. So that's the other reason we kind of moved away from some of that, and we moved toward patient navigator. Was that the absolute right decision? I don't know, but we think it was an appropriate decision. But then over these last couple of years, when we stumbled onto with our colleagues in the community college system, we're thinking, oh, we need to back up. So that's why we've gotten into looking at maybe moving toward health navigators. So if you hear us talking about community health workers, patient navigators, and health navigators, please just realize I'm schizophrenic. I'm not real sure which one I'm supposed to be using, and I'm using all three of those, fairly interchangeable at this point in time. I look to the future, I'm hoping that that will get clearer as we move forward with this. But for you guys, if you're using any of those terms, we're good. Don't worry about it. Okay, the definition. When we're in school, we always have to have definition, right? Well, that's easier said than done, because guess what? Of all the different programs across the United States, there's probably almost as many definitions of what these folks do than there are programs. So the American Public Health Association, which, when I have public health, I'm all aware of my Public Health Association, they came out several years ago with their definition. And what happened is that several states and other groups have tagged on to this definition. And as you can see, I'm not going to read it because you can read, but community health worker is a frontline public health worker who is a trusted member of and has an unusually close understanding of the community served. That's pretty potent words, which we've talked about a lot over this last couple of days. I think you agree. Words like trusted, from the community, or understands, have unique knowledge of the community that they serve. Very important. So, now a little bit of history. Now, are we the people who have designed this and came up with it? No. This role has been around since the 1800s, okay, in Russia. Some of you probably read some of the history of community health. And I have no idea how I'm supposed to say this, field hazards, but that is the right spelling. And that in Russia, there were these non-doctor, non-medical people that helped with health education and helped with care, health-related care. In 1920s, this is better documented in China by a Dr. John Bryant, who had gone in, Jonathan Barefoot, his name is Bryant Barefoot. He actually developed a program, because in China, they had a lot of people there. And they just didn't have enough providers, doctors, okay? Even in the 1920s, we had doctors. And so he trained these farmer scholars to actually do some assistant kind of work to support the work of the doctors. And they were called the Barefoot doctors after him. And he did that. He had a grant that he went and did that. And then, of course, we know what was going on in the 1920s and the 30s, the Depression and the global depression, and a lot of what was happening, war. So it wasn't until the 1960s that we started seeing our own federal government got very interested in this other health worker. And our Native American culture, I don't know if any of you have contact with that, but they've been using this kind of worker all along. It's very culturally accepted to have these folks that maybe had some additional education, but then did a lot of the health care in our Native population. So our federal government said, gee, that's interesting. So some programs actually came out. Those of you, I have a few people in here, maybe remember the 60s. But you know what happened in the 60s with not only the civil rights movement, but the feminist movement, a lot of movement around social issues, correct? So in that time period, there was interest in the government, federal government actually coming in and dealing with issues such as poverty and trying to assist those folks that may be having poor outcomes that we think we can do something about. And I was part of some of this because infant mortality was running rampant. And guess what? It's not doing great now, but it was running rampant. And so some of these first programs were around maternal child issues. But in 1998, we had what was called the National Community Health Advisor Study. It was a national study. It involved more than 200 people. They did interviews with key people, they did surveys, and they put together a report. If you have any interest, I have that listed in references, but it's easy to go find this. It's kind of like the Bible of community health worker practice, okay? It kind of laid the groundwork from a national perspective about this movement. And then in 2007, HRSA, y'all know that stands for the Health Resources Services Administration at the federal government level, all right? They commissioned the National Workforce Study. And in 2007, they published that study. So see, you understand, when we first messed around, I wasn't particularly aware of some of these studies. Probably Dr. Smith was, but I wasn't. But anyway, we did find them. And of course, they were pretty monumental. But see, they're governmental reports, which you don't necessarily pick up when you go to the medical literature like us doctors and nurses do. You know, we're kind of. In 2010, which was very interesting to me, our Bureau of Labor Statistics actually recognized community health workers as a legitimate workforce. And the definition that's in that code is very, very, very similar to what the Public Health Association published, okay? So therefore, what that did was set the tone for community health workers to be included in the Affordable Care Act. Did y'all know that the community health workers are in the Affordable Care Act? It is mentioned by name, community health workers. And it's actually in there that actually sets forth this workforce that not necessarily get direct reimbursement, okay? That's not exactly what that did, but it does allow for Medicare and Medicaid to recognize this workforce. So that's pretty monumental, all right? And then in 2013, the Center for our Medicaid at the national level has come in and reinforced some of this, and also with what we call, in fact, I know Virginia, we didn't get one, but they commissioned several studies across the country to look at innovative way for payment of medical bills. And some of you are in states, I believe, that maybe actually participated in this. Very interesting, and so what people were doing is going, gee, if we have community health workers helping support our medical care teams, we get better outcomes. Well, it's more than just that. Right. I am not as familiar with the Corey, but I'm very familiar with a lot. But that's where some of them went, yes. So there's been money flowing into this. So the question is, why now? Well, I just kind of answered it. We know that we got a broke system in a lot of ways. We got to figure out how to get, and we just went over this, didn't we? Better care, improved care, better quality, but at less cost. So, and then over this time, there have been many studies that have come out and very much well demonstrated the effectiveness of community health workers on patient outcomes within settings. And I'm going to give you some examples here in just a second. Then we kind of mentioned earlier today, and I'm just going to mention it because we could talk the rest of the afternoon, on value-based financing. Have y'all heard that term? Some of you are shaking, some of you maybe not. What we were talking about with this diagnostic-related categories and how people are paid and why is it that a hospital don't want to keep patients around because they can charge all that money, right? Well, no, they get cutoffs. Well, the federal government is very interested in looking at a way where you not only have, okay, we're going to pay you this $500 for you to take care of that patient with XYZ diagnosis, okay? And what we're now looking at even beyond that is you get incentives if you do it better. And then how do you know you do it better? Remember what Daniel was talking about. You have to have ways to measure that. And hospitals are going nuts doing all of this, measuring length of stay of hospitalization, readmissions, all that good stuff. That's what's happening in the world. And community health workers are being looked at as a way to help make that happen. So we're at a very exciting time. So there's federal interest, and then at the state level, there's lots of interest. And then, as you heard, the person-centered medical home, which Shirley just did a nice job of telling you all about that. So there's many studies out there, and in fact, we've done some of this review, and it's like over 200 studies that we found just in the last like 5 years or so, that things like heart disease, cardiovascular disease, helping people take their blood pressure medicine so their blood pressure will come down and stay down, all right? Diabetes is another one that's been studied a lot. And there's wonderful programs out there where they're doing patient education. Guess what? Community health workers are doing the education. Sometimes community health workers are teamed with a nurse and they do the education. I hate to tell you, but there was one group out of California, and they did one, they had the doctors doing the education, and guess what? They didn't do so well. Shame. I know. But so they changed their model to where it was the nurses and the community health workers that actually did the teaching and the training, and they went out into the community, and the folks would come. They had like these neighborhood parties, and the ladies and gentlemen, and it was particularly in a Latino community, and they had remarkable results. Actually getting people to reduce their hemoglobin A1C, which is a way that we can monitor diabetes. And they were much better with their eating, and they lost weight. I mean, all kinds of good results. And then, as I mentioned before, HIV screening, and then I was directly involved with the breast and cervical cancer program, where we brought in actually navigators. We used community health worker navigators, but VCU at the time then chose to add a nurse navigator. So we kind of married those two things, trying to get, because the grant out of CDC was focused on getting women of color into the clinics to get their breast cancer screenings done, their mammograms, their pap smears, that. And we were doing a terrible job here in Virginia. We were screening the white ladies. Well, they didn't need it as much, okay? So we added the community health workers, and guess what? Boom, we went right up, because we did that innovative community-based stuff, getting out to the historically black colleges, getting out to our black churches. Within a year, we had major change. Maternal child, I mentioned earlier, and this is where I came in. I had a lot of experience working with our Resource Mothers, which was mentoring pregnant teens, working with our Healthy Start, which is a 1991 HRSA-related grant that is still going on today, where we really worked with the infant mortality issues and premature birth. In 2010, Dr. Lewin did a review of 82 studies of this particular group in maternal child and had wonderful results, getting children in for immunizations, increasing breastfeeding rates, having reduced prematurity, having people going in for prenatal care. I mean, you know, a lot of good outcome. So it was like, gee. We also know in some of these programs we were able to reduce ER visits. Well, that comes home to roost for us, doesn't it? Because that's where hospitals can get killed on some of their activities. It's not just get people out of the hospital. Well, they got to get them out of the hospital, and they got to stay out of the hospital, or otherwise they get penalized if somebody gets readmitted within 30 days. So therefore, there was what was called the Coleman model. And this is a doctor out in Colorado who came up, and I'm sitting here going, gee, why didn't I do this? Because we've been doing this. But he had his 4 pillows, and he educated what he called health coaches. And you know what these health coaches did? I mean, this is pretty straightforward and pretty easy compared to what you guys are dealing with. patients who got discharged from the hospital with like diabetes or hypertension, heart failure, I forget, I think one was asthma, a couple of other medical diagnoses, okay? And they would train these health coaches, and they would go out and make one home visit in the first month. They made phone calls, and they taught them and worked with the clients, the patients, on their medications. Were they taking their medications? Were they able to get their medications? Were they able to pay for the medications? Did they have transportation to get to their follow-up doctor's appointment? And guess what? Coleman had wonderful results. Duh. You guys already knew that, didn't you? Okay? But he published, and he became famous, and he charges big bucks to send, some of you know about this, they send nurses and people out to go become health coaches, and he sits back and they train them, and they pay him thousands of dollars to go spend a week in Colorado. Yeah, well, that's not doing very much. And that's why he had good results, because we're talking about anybody that went in that needed some work on their blood pressure or whatever, you know, and so, but they were able to keep those patients from getting readmitted. So it was successful, and he's still out there doing this. So I mention him because he's pretty famous in this world of health coaches. They're not difficult patients. Some of them can be, because some of them could be the more poverty patients, but there's a mix. Yeah. See? Yeah, right. Now in Virginia, we have, and this is going on too in the AAA, the Area Agency on Aging, which is through the federal government, and they have health coaches, but they're working with Medicaid patients, and they're not the easiest patients. They're more like what we're seeing. But they're having pretty good results too, because it's that attention, it's that trust, it's that relationship building. All right, so obviously all of you are sitting here, and we've already proven, because many of you raised your hands more than once, okay? There's a lot of overlap, isn't there? The patient that's there, you know, are we talking a social worker? Are we talking a nurse? Are we talking a health navigator? What in the heck are we talking? We've got nurses' aide that go out on home health and do a lot of good stuff, you know, bathe patients, make sure they have food, you know. So is that a community health worker? I don't know. We could have that discussion, couldn't we? Health educator, and are you aware there's such a thing as health educators? Do any of you have health educators in your institution? Legitimate health educators? I'm not talking somebody that just, I saw a hand back there. Somebody has gone to college, has a bachelor's degree in health education. Yes. Yes, okay. We have James Madison University up in the Valley puts out health educators like crazy up there. I worked with health educators in the health department. They're not licensed, they're not social workers, they're not nurses, they're health educators. Many of you would qualify for that, except you may not have the credential in your pocket. You haven't gone to a 4-year school and got a bachelor's degree, right? But you're a health educator. I'm a health educator. Okay, so we have all these folks. Public health nurses. I worked with public health nurses for 26 years, and well, longer than that. And public health nurses are in the community. Public health nurses do case management. Public health nurses do surveillance, all right? So somewhere in all of that craziness, we need to carve out what is it that we want to see, I think, to help our patients. How are they unique? Well, and I work with community health workers here in Virginia, and we have interesting discussions. And it's a multidisciplinary group, and you know, sometimes I tread very lightly. I try to be polite, but you know, and they'll say, "Well, we're so unique because we're the only ones that do." And I'll go, "No, I've been doing that my whole career." You know, so but there is something unique about community health workers. It has to do with that connection. Remember earlier today we talked about the bridge, the link, that intimate knowledge of the community. And for us in sickle cell, it's that either that passion or that knowledge about sickle cell and the impact it has on our patients and our families. So see, somewhere in there, I think we can come together and really do something neat. So these are folks that do not hold professional licenses. They have that shared life experience. They may share the culture, and I think for sickle cell, we want them to understand the sickle cell culture, don't we? Whether or not they're peer, we can talk about that. That's another day's discussion. And that they can relate to the community more like their peers. You just gotta say something. Oh no, you're stretching. Maybe we all ought to stretch. Okay. All right, so what I'm going to present to you is what's going on in the literature regarding the core competencies. In other words, what should these folks be able to do? And I've made a little chart here. And remember the 1998 study, Koch, the national study, and then in 2016, another group out of the University of Texas did a national study of which Virginia participated in. And they brought all that together, they did a lot of interviews, and they put together this mammoth report. So if you're going to be in this business, you need to get the Koch study and you need to get the C3 study. They call it themselves, the consensus study. They were trying to get consensus on what a community health worker is, who they are, what their knowledge is, what their skill level is, what their abilities are, and what they value. And that report's got all of that in there. We had to do something before 2016. So we had already taken what we got from the literature, and Virginia had been involved in a study also and had come forth with their things. So we took the Virginia study, we took some from across the country, we took what was in the literature, and we came up with what we thought were our core competencies, which I'm going to share with you in just a minute, but from the literature. Now, I know I got somebody here from the Sickle Cell Association, and you need to come, we need to talk. I did reach out, but from the last document I had from the work that they were doing in last summer, we really marry pretty good, all right? So I just listed this, but let's just look at it. Providing direct service. Not a major area that people are doing. We're not expecting our folks to go out and take blood pressures and do blood sugars and all of that. It is happening in some areas, but it's not really prevalent in the literature, and it's not necessarily a big movement of what we want, is it? We really are into the psychosocial, but providing health education, right? Big time. And doing the counseling, social support, and getting people to the services that they need when they need it. So you can see here, I was trying to show you that those reports are all saying pretty much the same thing. Then we go down where it does begin to change a bit. The Koch study goes into about mediation. Rosenthal and the C3 project said the same thing. The Sickle Cell Association is silent on this. I don't mean to be ugly, I'm just saying they're silent on it. And there may be something there, I just don't know about it, all right? Then the next one is advocating for individual and community needs. We talked about that some today, right? Big role. How we define that? Ooh, I'm not sure. It came up today. I wrote on my papers, if we ever do this again, we need to probably dedicate a whole session to advocacy. What does it mean? What does it not mean? What's the difference between advocating for my individual patients versus advocating for my sickle cell population? You hear what I'm saying? It's different, isn't it? And I don't think we've really well defined that. And I know that our patient navigators do a fantastic job for advocating for the individual patients. I know they did some advocating at a community level because I was part of the team down at Eastern Virginia Medical School when they were on with us. But we didn't clearly really figure that out, did we? So I think there's room to grow and talk there. And then building individual and community capacity. That's a whole nother one that, woo, so you're expecting me as a community health worker to actually build capacity? I think that needs further development. And then the C3 project went on to add implementing individual and community assessments. That's like going out and doing a public health assessment of a community. That may be appropriate, may not, I don't know. But we just heard exciting news today about what's going to happen at the state level on looking at the data and everything. And that could be very important that our community folks are involved in that project in some way or have a way to feed into it somehow, don't know. And then conducting outreach. All right, so Then from all that literature, and I'm not going to go into all this because I know, where am I on my time? You could talk, I could talk all day. We took this and went back to the literature, and I listed then our 7 domains, which mirror pretty much what you just saw. It's all about navigation, care coordination, coaching and social support, and then went to the literature and looked at every single article and looked to see what were the navigators actually doing. All the way down to, were they making appointments for patients? Were they assisting patients make appointments? Because that's a different task, isn't it? Do y'all see the difference in that? You know, whether you're calling up and making that appointment versus are you sitting there and going, now, Joey, do you know how to do this? Well, this is the number. Let's call together and teaching them how to do that so that Joey can then do it for himself at a later time. That's called empowerment, isn't it? That's what this conference is all about. So, following up. That could be something as simple as calling somebody up, like what Donna does to remind them of their appointments. It could be a lot of different things. So therefore, in the literature, we went back and we looked at every single intervention, if you want to call it, activity, task, whatever that article called it. We went in and looked at it and listed it. That was a pretty tedious little task, but anyway, we did it because it was very interesting what was said in the literature about what this person does. Now remember, this was done after we'd already got our program up and running, so we were kind of floating by the seat of our pants on that. But we were pretty good because we did base it on the earlier works. And from what I can tell, we hit pretty okay. All right, under the culturally competent health education, everybody across the country really does believe this. They go, oh yeah, this is the role. Community-based, health education, culturally appropriate. There's really no disagreement on that one, all right? Direct service, yeah, there's some, you know, we didn't really have we had a little bit though, when you really look at it. There's a little bit of, and it depends on how you define it, because that can get kind of tricky. But anyway, we did the best we could, but there's a little bit. And then down to participation, evaluation, and research. Obviously, our patient navigators have been involved in data collection and doing some of that, which is an appropriate role, and we feel is an appropriate role, and the C3 project agreed with us, which I thought was nice, because we're doing it, and they came in and completely supported what we were saying is an absolute appropriate role to help with community assessment, collecting data, and being aware of that, because as a sickle cell community, we want to get more and better data about our patients and where they are and what's happening and all of that. Not just hospital-based data, right? Because the hospital-based data is somewhat skewed. All right, advocacy, now this is an interesting one. As I said, we put it in our little 7 domains because we knew our navigators were going to advocate at least at the individual level. And most people across the country listed. What's interesting, it has not been studied or well defined in the literature. So there's a whole area of research that we can do if we got to it. And then the outreach and case finding, and this Shirley mentioned earlier about, we learned some lessons about case finding, and we finally had to back up and go another round. Because of just what it is. How about what?
I said make a point about advocacy. Warrior University is the source of that group.
Yeah.
Is interested in self-advocacy. They're interested in having patients learn to advocate for themselves.
Right.
And feel that peer mentors, CHWs, can train patients
To
how
advocate.
better to talk to the doctor when they go to the university.
Exactly.
How to put on your lipstick.
Yes, because we obviously, we're going to touch on it again tomorrow when we get down more into the weeds of some of the things, and we've got some information in your spiral notebook about that. That we feel is a very important part of that advocacy. Empowering, giving information. We talked about it at lunch, where I was at lunch today. How do we do that, and what is that, and what does that really entail, and how do you do that, and then as a parent, not only how do you do that, but how long do you do that, and when do you relinquish that role, and how do you go about doing that? I've heard that for the last 2 days. Challenging stuff, isn't it? Okay, so we just threw it out here that this is kind of where we're moving, and that we see, I hope I'm speaking the truth, that there's a role for a community health worker, navigator, in this world of sickle cell disease. And so as a sickle cell disease community, we probably need to think through what could be our definition. So we've just thrown one up here for you guys. It's in your spiral notebook. And at some point we could talk more about that. Because we're not the end all to this. But we're hoping as we move forward and we stay connected, and those of you that are going to stay and work with us on Friday, this is something we may want to be doing. Because wouldn't it be nice if we could partner with the Sickle Cell Association, Sickle Cell Association of America, and as maybe a network of sickle cell hubs, as you refer to them, if we came up and said, this is what a sickle cell disease health navigator is, that would be power, and that would be empowerment. So, the roles and functions of the sickle cell disease health navigator. Well, this looks a little familiar, doesn't it? All right, but it didn't come from we didn't just pull this out of the air. This was from our study, our experiences, and what we've learned, and we feel comfortable that these are kind of the overarching roles and responsibilities. And we have them all written down for you. And so you've seen this slide before. You see it here, the patient navigator. And as time goes on, we may want to change that to health navigator. I don't know. We're not at that point. But certainly the role we are valuing. And the team that you've heard from obviously values it. And you heard from our navigators who are phenomenal. In fact, I don't understand why they're not standing, but you're going to hear from them in a minute. All right, not just me. I'm the book lady. So therefore, how are we on time? My colleague is going to join me unless do we have time, Shirley, for a couple, or you want to move on? Just let me know. Any comments or question, or if I just rung a bell? Yes, ma'am.
Was there any issue in your institution with having a role that goes in and out of the hospital?
Oh, good question. I'll have to defer somewhat. I don't remember hearing a huge problem with this. No.
So there weren't any barriers?
Yeah.
Administration or HR?
Yeah.
You get HIPAA training.
Yes.
See, some peer mentors never get HIPAA training, so they can't look at HR.
That's right.
But once you get HIPAA training and you can look at HR, it doesn't matter whether you're looking at it on the inpatient side or on the outpatient side.
Right.
You're just able now to enter into a more, a deeper knowledge of the patient than you would have had just
Right.
from talking to the patient. And by the way, I don't even know if we talk about that in our classification system. HIPAA versus no HIPAA.
Oh, you know what? I'd have to look. We may not have made that a distinct,
I think that
is it important? Right.
There are certain things that you will not be able to do if you do not have HIPAA.
Exactly.
In your client's
Right.
patient
Right.
chart.
I think in our hospital, the silos of inpatient versus outpatient are so great that conceptually, people are having a
Hard time.
thinking of someone going out. and
Exactly.
in,
Right.
But we're stressing that's really what you need.
Right.
It's not
Right.
really the
Being,
We observe that people who work on the inpatient hospital side don't view themselves as having the time to go to field visits.
right.
And so they have a larger caseload. This is anecdotal, a larger caseload and a narrower job description for that caseload, and they don't venture away from their office or their floor or whatever to do their work. And the patients sort of come to them on the wards, wherever they are, as opposed to the outpatient side, if that's what you do mainly. You might have a smaller caseload because you got travel time in there.
Yeah.
We pay for travel time. So that's a distinction. But if you can follow somebody in and out, our experience is that you get a stronger bond, there's more identity of the patient with you, and they sort of feel you're working for them, not just for the hospital.
Right, right. And being here, this is where our team has been pretty cool, in that with our expert, Dr. Smith, and Shirley with her social work background, and me with my public health nurse background. See, that never was a concern for me. I was so used to being from the public health world that, you know, if you get your HIPAA training, you've done your proper orientation, and you have the folks oriented, and you've worked their partnership with your referral sources, you know. And I've worked with a very vulnerable population, and that was pregnant teens. And we worked in and outside of the health department. But I had folks, ladies from the neighborhood that went into the home, came into the hospital when she would come in and have her baby, and we never had a problem. It was just that communication is the key. So I don't remember us having a major, but I could understand maybe some institutions, but that's part of that, what we're talking about a little bit on Friday morning, I think, and what we've talked about is that process you've got to do. Well, that's one of the things you got to deal with. And I think, too, the other issue that's going to come up when you're dealing with peers, and we did have that, is that whole confidentiality and making sure that, because that can get a little tricky if you've got a patient here and all of a sudden you're going to assign them to that patient. It's like, uh-oh, that's a little too close for comfort, and they really shouldn't be viewing that chart. So it is an issue that needs to get addressed and talked about, but I think there are ways to deal with it. I mean, and I spent many years where we used to have health department nurses came into the MCV hospitals and assessed patients on the unit for referrals. And one other thing that I did think about is one of our challenges is that once we started doing this, remember back to the titles, we have found that there are community health worker folks within our hospital that do not consider themselves community health workers, but they are. They call themselves outreach workers, I think is the term. You know what it is? But when you start talking to folks, they're doing this kind of work. So it's that whole discussion of function versus what are we calling these people. And I really think that's going to be critical for us to move forward, because right now it's still a lot of confusion in the country. And there's states that have moved forward, like Minnesota, they have completely put their community health worker movement within a certification program within the community college system to kind of take care of some of those issues. And there's other states that says, not going to do that because it's too limiting. We want to stay individual. We want to be unique. We want to be outside of the system. So I don't know the answer. There's a question back there.
I have a comment.
Yes.
Our agency, the Sickle Cell Association in Norfolk, Virginia, participated in the Sickle Cell Disease Association of America class, the first class that they actually had 10 hours.
10 hours?
A week for 10 weeks.
Oh,
That we
okay.
had complete
Woo-hoo.
that,
100 hours.
for certification as a community health worker was the term that
Good,
they're using.
good. Right,
And that was under the HRSA grant that we all had at that time.
right.
In order to go forward with the project of Get Connected, where we were getting patients from across the country.
Exactly.
In this portal of
Right.
information, health information.
Right.
So it was a certification requirement to complete that. We had a proctor exam, which was
Yep.
extensive, that the student had to complete at the
Exactly.
end of those 10 hours, 10 weeks.
Right. And that, thank you, and I appreciate it, and I'm aware of some of that, but I haven't been as intimately involved.
Detailed description I've ever heard.
Yes, I know, and I wish I had been more intimately involved. It's not lack of interest, it's, you know, just to get involved. It's hard sometimes to reach out, but,
And they offer that class each year.
Yeah,
since
okay.
that time. And
Right.
I think it starts in October.
okay.
Um,
And,
it does.
but, yeah,
October, and
this
it
is,
runs through.
you bring up an excellent point, which I'm going to talk a little bit about Friday morning, is what is the right number of hours somebody needs to sit in a class? Do they need field experience? Well, how many hours is it? You realize it varies from 2 hours to 240 hours across the nation? So we don't know what the right hours. Certification, there's, I think, right now either 7 or 9, I've got that on my other slides, that have a certification process. Virginia just started theirs. Maryland has been a step ahead of us, but then Maryland has some issues with the way it's done. So there's just huge variances. And this is where I think we need to move forward is really, I think as a sickle cell group, we can say, y'all can do whatever you want to over there, but we're gonna do what we're gonna wanna do. And I think that's where we meaning us that are working in the sickle cell centers and hubs, working with the parent groups and the association, wouldn't that be remarkable if we kind of came together and said, okay, this is what it ought to look like? Because we don't know. We really don't know because it hasn't been tested. But guess what? You guys are kind of guinea pigs. Hate to tell you. But that's part of what we've been trying to do, is to really go out, do some of this training, and then really evaluate it so that we can come back and say, you know what? You need those 100 hours. Or you know what? You could probably do with 50 hours here, but 50 hours of field work, and you could get the same. So I don't know. I don't have the answer, but I'm glad to hear it, and we need to talk more. I'd love to talk more. You had a hand.
Yeah, so standardization and best practices, I think, is really the way that we have to mobilize. But part of the reason for doing that is also to make sure that that every institution is putting their money where their mouth is, because the undervaluation of community health workers is an actual atrocity. They are hiring people from the community to do what they know they can't, and yet they are paying them less than their
Pennies.
worth
Yes.
for what they are saving the hospital and what they are addressing.
Exactly.
So we can't,
I understand.
we can't ignore that piece.
That's right.
In an effort to just simply be recognized by a title.
Right, right.
And then, although I'm in Minnesota, and although that there are community colleges and things that do actually have certification programs and they actually have credits and things, the biggest challenge in Minnesota is implementation, because it's all about the reimbursement.
Yep.
And so that is institution to institution to institution. And even in the institution where I'm at, thankfully, I got my CHW certification through SCDAA as well, but I got it after I came into the institution, because that institution does not hire CHWs because they can't agree on what reimbursement could or should look like.
Yeah.
And had I been hired at that, my paychecks wouldn't even look the way that they do, I'm sure.
Right. Right.
And so, not that they look great, but I say all of that to say that and the NACHW is out there, the National Association of CHWs, and they are aware, and there's a lot of efforts from a broader sense. But I do agree that the sickle cell population has some unique characteristics I think that some of our best practices, and we need the strength of one another, right? Many of us know one another in many different settings, but we need to be talking to one another because we got the same issues in different states that we can talk about.
Right.
So.
Okay. Well, and to kind of piggyback off on that, I think that's why whether we agree on those 4 components or not, what we were talking about yesterday is, if we have a centralized identification system of classifications, it's a start. Because when I was at the Synergy conference, and the gal's not here who I had talked to, and I think Stephanie and Marla might have been in the session, they were talking about, well, we can't go to CMS for reimbursement until we have each of the 50 states coming up with their definition of community health workers and blah, and I'm like, wait a minute, that's absolutely ridiculous. So I'm kind of thinking that if we can somehow get some empowerment out here, and then we have people who could go to CMS and really advocate, then I think we're heading in the right direction. So we'll see what happens.
We'll see. All right.
All right.
I'm going to turn it over to my colleague.
I know everybody's tired. I'm going to try. I feel this is very important, but I also know you're all just about, learned out. So what I want to do is I want to go through some things that I feel are really things we should tackle. If you feel I need to stop somewhere because you think it's more important than what I'm kind of paying attention to, raise your hand. Otherwise, maybe we can come back to it later or even in the training session for those of you that are staying. So basically, what I want to talk about is the 3 key traits of positive patient-provider relationship building. Which, of course, the first one is empathy, and we all know what that is, okay? We want to be empathetic and understand and share the feelings of people that we are working with. We also want to make sure that we're communicating effectively and getting our message across the way that we need to. And we also want to be able to provide that positive patient-provider relationship by listening, like Taylor had talked about, listening, explaining, trustworthiness. So what we're going to do is kind of just talk about this a little bit. And although, we all have relationships in our lives, Some of them are good, some of them are not so good. Hopefully the positive ones are what we build on when we come to work every day. So you want to treat people fairly, equally, and you want to remember that even patients who sometimes frustrate you are human beings, and you want to treat them with respect and dignity. So you want to make sure that you're keeping those things in place when you're working with anybody, really, but in particularly when you're working with people with our population. So again, I think empathy is something that we all should value as human beings. We all have personal struggles. Whether we come to work and we bear those, I'm a little bit more forthright about some things than other people that I work with, but I also think that we also need to be aware that people have bad days, and there's sometimes reasons why that happens. For patients with sickle cell disease, that could be almost any day or every day, depending on what is going on with their disease. So we try to have to keep that empathy piece into play, even when we're frustrated. So, oh, I'm sorry, I thought she was saying something. What we want to make sure that we do is also embrace our clinicians. Physicians are great people, but in medical school they're taught science. They're not taught psychosocial behavior. They talk in a way that sometimes none of us understand. So when you look at statistics, over 65% of patients feel that if their provider would have what they call clinician empathy, they feel that they would be treated better with their overall care. Patients want to feel heard. Again, try to go in or prepare your patients to go in there with questions about things they don't understand. It's their life, their body. They should be able to ask those questions. Providers do have a limited amount of time. You know, we all know how the insurance regulations are, 20 minutes in, 20 minutes out. But if you come in prepared and you show the doctor that you care as much about yourself as they do, I think they're going to find that they'll spend that quality time with you. And I think sometimes the doctors feel like, okay, I'm saying the same thing. It's like me. I need to lose 40 pounds. The doctor every week says, you shouldn't be doing this and you shouldn't be doing that, and I come back and the scale doesn't change. Well, at some point in time, the doctor's going to be like, well, you know, you don't care about your weight, so why should I care about my weight? It's the same type of thing. Maybe not so much, but in my world it is. Strong communication. So I believe it's tomorrow. We're going to get a lot into more of the communication skills, motivational interviewing, all the talking points that we feel are important as health navigators and social workers. But it's also very important to send positive patient relationship communication through clear medical instructions, providing education to patients at the level that they can understand. Do not assume that every patient who sits there and nods their head understands what you're telling them. We did a 1-week survey in an inpatient setting right before this program launched, and found that 40% of the patients we discharged in that 1 week did not understand their discharge instructions. And they were afraid to tell the nurse or the person who was telling them what they needed to do when they left. So imagine how many of those people are coming back to the hospital because they didn't get their prescriptions filled properly, they didn't know how to take their prescriptions, they didn't know how to schedule a doctor's appointment, and yada, yada, yada. So those things are really, really critical. And again, talking about literacy issues, which I believe also Joan is going to get into tomorrow, so I don't want to stand up here and talk about that too much. I think Marla, I think Stephanie, they both touched on this quite a bit, and it's really just having that trust relationship, educating them, understanding the cultural perspective. And I think tomorrow is a good time to really get into this a little bit different, but when there isn't an understanding of cultural perspective, how do you make that work? Because all of us, of course, here are not African American. So we have to be able to understand the cultural barriers if we're dealing with individuals who are not like us. So I think that's a really important conversation we're going to have tomorrow, and hopefully you all provide some positive feedback on that as well. Boundaries. This is really important. I think it's really key that we recognize professional boundaries when we're working with patients. We had a wonderful woman here for many years who was a nurse practitioner, social worker before that, case management, you name it. And the patients absolutely loved her, but she did not follow ethical boundaries. She had them over for tea, they went shopping, sometimes they came and stayed with her. All the things that you all want to have people do for you, but you all know that it's not appropriate, okay? She didn't get fired, she ended up retiring. I will tell you, she was the most wonderful person, and the patients still talk about her today. You know who I'm talking about. But there were times when it was like, oh my gosh, please tell me she didn't do that. So we kind of just didn't say too much. So again, know your limits. I think that one of the things that we find out here in the job, I've been doing this, like I said, about 20 years, and one of the things that you need to know is what you can tolerate as a professional. And if you don't know your own boundaries, you're not going to know really how to deal with a patient. You need to know your physical limitations, what you could deal with emotionally, how you could take care of yourself. Self-care is really critical when you're dealing with a high complex population. Red flags. Know when you're not having a good day or a good time. And if that's the case, try not to impose that on your patients. We have personal struggles. Sometimes it's with our children, our spouse, whatever the situation is. If you are really having a bad day, try to keep that in check or stay home. Be direct, but at the same time, show that empathy. And I think Marla was saying that earlier. Sometimes it's a tough love thing. There are times when you're going to tell somebody something they just don't want to hear, like any of us. Nobody wants to hear things about yourself that you really know, or maybe unconsciously don't know, and somebody's bringing it to your attention. But when you're really having situations that involve your personal health, I think it's important for us to be direct, but at the same time, understanding the way we need to communicate with someone. Give yourself permission to be wrong. I'm wrong, I tell my staff 3 to 4 times a day. Maybe longer. Half the time I'm in flake zone somewhere and they're always trying to correct me where I need to be. But always admit that you're not perfect. You make mistakes. Patients make mistakes. Recognize that you are not perfect and go ahead and give yourself permission to deal with whatever you have to do when you make a mistake. Practice self-awareness. Be attentive to your own feelings and honor them. You don't have to like everybody you work with, and you don't have to like everybody that you deal with. But when you're in a professional setting, somehow you all need to figure out how to get along. Consider your past and your present. And tomorrow when we talk about stigma and bias, which is going to be a very uncomfortable conversation for some people, you were raised a certain way. You're not going to change a lot of your beliefs because you were raised a certain way. And that's okay as long as you can understand that your beliefs might not necessarily be my beliefs or someone else's. So you need to have a mutual respect for individuals and realize sometimes that your own biases can get in your way of dealing with people. And your family role can be draining to you as a professional. If you're having a tough time, if you have a child that's ill, it's hard to go to work knowing that you have somebody at home or that you can't be there with them all the time. I'm really big about this, and I'm just going to escape over this just a little bit. It's in your manual, but I think it's really important. So make sure you know where you're going. When you're going out in the community, make sure you know who you're going to see, where you're going, and if you're comfortable going there. I worked for a child welfare agency, and that is the most challenging job anybody could ever have. And I was in the intake department, and so my job was to go out there and find out why this person was calling in this report and reporting somebody for abuse or neglect. Well, imagine I was not the friendliest face they wanted to see. And I would bounce in there and I would be like going into these situations where I was still young and dumb and didn't know any better. And as I learned, I kept saying to my supervisor, I don't really think I should be going out there by myself. This is a pretty serious case. I think I'm going to be... And you know what? And they were like, no, if you can't handle the job, you shouldn't be here. So I do not feel that way. And I always try to say to my staff, if you don't feel comfortable going somewhere, you take someone with you, you meet them somewhere else. I don't care what the situation is. To me, your safety is the #1 issue that I'm dealing with. And I hope that they feel comfortable coming to me. I mean, most of the time, I think they feel pretty okay with where they're going. But when we started this program, I insisted they had phones. I insisted that they had a way of getting in touch with us. And even though they take phone calls after hours, which they don't need to do, they also are known that they should not be going out and working with people past a certain time of the day. You know, and those are things that we really try to stay focused on. Wear your name tag, make sure you call before you're going, make sure your tires are not going to go flat. And sometimes things happen. If you want to carry pepper spray or something, you can. I do think most of the time our patients know we're coming, and for the most part, it's not the situation like I experienced, but just social work 101. Don't put yourself in that situation. If you have a supervisor that's not really accommodating to you, you need to go find somebody who will, because your life is just as important as someone else's. So again, these are just like parking tips. If you go to see somebody, what you should do to make sure that you're safe. A lot of times, I believe, even if there's a scheduled home visit, Taylor, Marla, or Stephanie will call, just say, hey, I'm still coming. Maybe somebody doesn't greet them at the door and turn the light on and all that kind of stuff. But if you're going somewhere, you probably should make sure someone is going to be there. You know, always use I statements. When you're in a conflictual situation, make sure that you always try to go back to, I understand, I can empathize. And again, Joan's going to touch on this more tomorrow, but you know, making sure that you put yourself in a situation that you can get out of. Again, child welfare story, many of them, I can assure you after the years that I did it, I always made sure that I had a way out. I always had my back, you know, where I was facing somebody. I knew where that door was, and I never put myself in a precocious situation except one time. And one time was almost one time too many. So always try to get yourself in a situation where you know how to get up, get yourself moving, get yourself out of danger. And always call your supervisor as soon as something happens. I think, again, this is just, you know, things that I think are important. But as an institution, you really should be going through your processes and responding to home and safety issues. As mandated reporters, you must report abuse or neglect. We do not feel comfortable doing that in our department. It's not something that we believe we should be doing all the time. You, by law, need to report it. It's up to somebody else to investigate it. It's not up to you to determine whether or not an investigation should go forward. So although, again, I like to think we don't run into this too many times in the roles that we play, you never know if you're going out to see a patient and they're an adult and they have a child in a very challenging situation, what you need to be doing. You need to understand your responsibilities as a professional. That's all I'm going to say. You know, I think, again, if you believe somebody is depressed, anxious, or sleep deprived, if you are fortunate enough to be able to report that to someone like Taylor, and hopefully she could take the reins from there. You want to make sure that you, that a patient, and I think this can happen more than we know, is not being taken financially, that finances are not being abused by someone else. That happens a lot. Some of our patients have cognitive limitations. They live with families. Families think that they owe them something for taking care of them as adults. And we find there's a lot of mismanagement about affairs. And you need to make sure that you're taking the patient's best interest at heart. Again, these are styles about some of the things that you should do when you go to a home visit. Acknowledge all the people in the home. They're just as important as the patient. Introduce yourself in the role that you have. Once, of course, that patient has met you, they should know you. Hopefully the family members know you. Try to give them an impression about how long you're going to be there. Oh, you know, our visit's scheduled from 3 to 4. You know, I do have another appointment. You know, try to be courteous, try to be on time. If you're not going to be on time, please call, just like you would want them to call you. Explain what you're going to do while you're there and what the future is going forward, especially with our population. It's not one and done. You're going to probably be working with them for some time, so just kind of give them an idea about what your role is. And thank the family for allowing you to come, especially if you're going to their home. If you're meeting them somewhere else or you're meeting in the clinic, you should still thank them. But by somebody letting you come into their home, like all of us, we want our home to be respected. Again, 8 principles of effectively maintaining professional boundaries. Somebody, I think it was Kyle, used the word empower. Empower is one of the major words in Social Work 101. So you want to make sure that you're empowering that patient and not always rescuing that patient. Take care of yourself, like we talked about. Service time is not me time. Therefore, you don't ask a patient to come and wash your car. That's a crazy example, but I know some people would do that. Try not to give people money. I know we feel bad sometimes for people, and I know we've all done it, okay? But just be aware of what those boundaries are. Don't shift from service provider to employer. Again, you're not going to hire that person to come and watch your kids. Common sense, but sometimes it happens. Be consistent. Try to be a role model. A lot of the people that Marla and Stephanie were talking about are those 18 to 30-year-old patients. Really, that's our most vulnerable population. I'm not saying that those over the age of 30 are not vulnerable, but they might be vulnerable in different reasons. be a role model. You're a young adult person, well, whatever your age is. And, you know, let them know, hey, you know, especially for patients here who are working in the field, I have sickle cell disease too, but I come to work. You know, we have people that are nurses, pharmacy technicians, some people have worked for the government. Now, maybe you can't physically do all those things, and that's fine. But let them know that it's still okay. You have a disease, but that still doesn't mean you don't have to do something for yourself. And we really try to do that for our young people. We really don't try to go from, hey, you're graduating high school and let's put you on SSI. We'd really like to try to have you do something. What is your skill set? What is an interest to you? Now, of course, if they can't work, that's a different story. But we really do try to make them accountable for something that interests them. Advocacy, boy, we could talk about this all day. And I know if Dr. Smith was here, he probably would not be happy with me that I'm going to probably go through this a little bit quickly. But I think it's really important for those that cannot advocate for themselves that that's where you spend a lot of your time. There are individuals, including people sitting in this room, that not saying you don't need someone to advocate for you, but there's other people out there that you could help advocate for themselves a whole lot more. And it's really important that if somebody cannot have a voice for themselves, that you be their voice. As a parent, you're going to be their voice if they need that IEP or 504 plan. So when they're an adult, sometimes they need it even more because sometimes their families are not there for them. I mean, I think about a lot of our patients. Not all of them are you know, poor and don't have stable family supports, but I think about our young men in particular, a couple of young men that we work with. They've been in jail, you know, they have no family, they're living in the projects, they have nobody who gave them a chance. You know, we want to have that one person that gives them that chance so that they can see that there's more to life than their disease or the situation that they're living themselves in. And we've done some really great work. We'll talk about it a little bit more, but we've been able to put a little bit of a program together to get some of those young men into stable housing, which has helped stabilize their lives. So we've been very happy about that. Advocacy is to me, is the number one thing you do as a health navigator, a social worker, a nurse, any of us. We really should try to be there to advocate for people. There's 4 different types of advocacy. Some of these go back a way, and some of these are more prevalent. The one that is really focused on today's age is the triple aim. And that is really what is coming out, that you want to focus on the key core components that I think Dr. Smith touched on yesterday. And again, I don't mean to keep deferring to Joan, but this is part of her presentation that she's going to be going over tomorrow. But it's also talking about what that means. So we talked a little bit about case management. Don't want to really go into that again. But I want to talk about the 4 primary case management practices. So paternalistic is very much that helicopter mom doesn't want to let go. They want to make sure that everything's there for their kid, even if they're 35. I'm a mom. Trust me, I get it, okay? And it's hard sometimes. I mean, even if my son doesn't have both my boys don't have a chronic disease, sometimes it's hard to let go of some of those things. I still know that, you know, it's nice when they call you once in a while and say, hey, can you help me? Oh my gosh, I'm still useful. So, you know, but there's that paternalistic role that you want to make sure as a case manager, you're trying to stay away from it if at all possible. Again, we talked about empowering. I can't say enough about that, but we'll talk about that more through the next day or two of what we feel empowerment is as far as the role that we play. Shared responsibility. You have your job, they have their job, you come together, you talk about what's realistic. Sometimes people have unrealistic expectations, like Dr. Sisler talked about our young patient, or was it Indy? I forget who, Taylor, where we had this young man. He did great in high school. He was on the football team. He thought he was going to the NFL. We had a gala where Ryan Clark, if any of you know who he is from the Pittsburgh Steelers, my team, even though they're not doing too good. But Ryan Clark came and talked at a gala, and we invited this young man there, and he's telling Ryan he's going to play for the NFL. And Ryan's like, no, son, that's not going to happen for you. He really thought that was going to happen. So what was realistic for him? Maybe he could have still helped coach a team. Maybe he could have done something in the way that he loved something, but he was so focused on going off and playing college football and then going to the NFL that I think that when he really became ill, that was very hard for him to overcome. So I think it's important for us as individuals to provide or help support realistic expectations. We're not always going to be successful, but I think it's a good try. And then, of course, we want to talk about engaging. Again, trying to get the patient, the patient's family, to really think about how they want to move forward with their self, giving them the counseling and the support that they need, respect their autonomy, have self-control over themselves while the case manager functions as the catalyst for change, but they in turn are doing something to empower themselves. I guess we'll skip over that. So, as we're wrapping things up, I want to spend the next 5 minutes with, once again, Marla and Stephanie coming up here and just telling you about what they do for the day, and then we'll kind of wrap it up for the day. I think we have one more giveaway, if I'm not mistaken, so, okay. I know some of you, are some of you not coming back tomorrow? I think it's just our peds, right? You're coming back. Did you get a prize?
Okay, so aside from what we already mentioned, I sat back there and thought about some other things that we do. So everything is done behind research, per se, some of it. And so we do a daily Excel spreadsheet that says who was admitted, when were they discharged, who follows them, whether it's me or Stephanie. And we kind of keep a track of who has a 30-day readmission. And if they do, there is a form that goes with that we give to the patient, and they fill out why they were readmitted. Did they not have medication? Did they get an appointment when they were discharged? Did they not get an appointment? What's your diet like? Those are some of the things that are on that form to try to help us keep track of why they could have potentially been readmitted. And we also try to go see them once they've been discharged. Another thing that happens, which has been happening since we've been in this conference, is every time a sickle cell patient comes into the ED, it comes directly to our phones. And so if it's someone that we work with, we may call them, or we may go down to the ED to see what's going on. Sometimes they need a prescription, and that will get them out. And so if that's the case, then we call Micah. She'll write a script. I'll go get it, take it back to the ED. If they need a PA associated with that prescription or prior authorization, then I call Austin, and Austin steps up and does his thing. And then I let the patient know your PE is in the works. PA is in the works. Let's see, sometimes we have to go to the ED just to de-escalate a patient if it's someone that we really have a good relationship with. It's just a matter of going down there and sitting with them in the ED. I have wheeled patients from the ED to an outpatient clinic appointment. I have called transportation for patients. And this is really weird. This happened on Friday, I think it was. A patient lives here but's going through some things, so is in North Carolina, bouncing back and forth. So he was reluctant to go home because he didn't want to go to the home here with his stepmom. He wanted to go back to North Carolina. Ironically enough, I had no idea this would fly, but I called Medicaid transportation, and they transported him back to North Carolina. Yeah, so I don't know how it happened. I just said, so I just said, yes, he lives in Virginia, but he's going through some things at home where North Carolina is the safest place for him right now. So it's all in the wording, you know. So let's see. So there's been an influx of patients for whatever reason, I guess, with having the whole sickle cell home. That a few of our patients are abusing the medication, so they're being stopped, tapered down. There are no more opioids when they come into the ED. So leading up to that, Stephanie and I kind of let them know these are the behaviors that you're displaying. These are some of the things that the doctors are concerned about. that's when we may step in and start doing pill counts. We're on them, like trying to prevent that from happening.
It's over a period of
Right.
sometimes months.
Right. So once the doctor makes that decision, like we've had enough, he or she is not safe, then they call them into the clinic and they have that discussion with them. So when that discussion is held, if it's one of Stephanie's clients, she's in that appointment with them, or if it's one of my clients, I'm in that appointment with them just to kind of, give them that support and come up with other ways to kind of manage your pain. Not that we haven't tried that before, but just kind of reiterate because it's really happening. You don't have anything anymore. Of course, we do home visits. Yes, we do home visits. Let's see. Social services, some patients come into the hospital because they're homeless. And we can kind of pick up on those. So we may contact Caritas or other social services, homeless shelters, to try to get them into housing. And let's see, records, referrals. So we've had 2 patients leave. They had enough of us. So they just, one went to Tennessee, one went to Duke. So we send records, and then of course they kind of start doing the same things that they were doing here. So then we talk to those providers, and they get in contact with our providers and kind of figure out what they're going to do with them. So yeah, that's some of what else I could think of. Stephanie, you want to add?
We make appointments. We remind them about their appointments. We go to appointments. We go to other doctors' appointments with them. When they go to the hospital, we see them in the hospital. During the day, people come and go in the ED, in the emergency room, so we check on them too. We do documentation in the computer. We develop community resources, find out, what is available. We read the charts to keep up with what's going on with the patient, with their health care. We go a lot of places with them, We go to schools, to various social services, like Marla was saying. Like I said, I've even gone to a funeral with one patient, one client. Yes.
Oh, I have a two-part question. One, thank you. My first question is, do you handle incarcerated cases?
We do. In the hospital, there's a clinic that is a lockup. So we do go down there and see them when they come in and see if they have any needs that we can address. Yeah, the doctors have written letters, the providers, Micah also has written letters to, on their patients' behalf for various reasons, to go to various places, helping them get housing, the parole, get a treatment plan so they get the proper medicine in the facility. They make appointments for them so they can come to the clinic from the facility, so they're still getting their medical care, continuity.
Yeah, they even wrote a letter once so the inmate could get seconds.
Yeah, so we could have more food, because when your sickle cell causes your body to run on overdrive constantly. So this young man was hungry, so he wanted more food.
Were these cases that you had here, in your area, or were they cases that came into the state and were incarcerated in the state penitentiary and then contacted your agency?
The people I've been involved with have all been Virginia residents.
Okay, because I've gotten some that, found us as sickle cell program and then contacted us about that kind of help, and we had no doctors that would write a letter, anyone who would write anything on their behalf, because they were not initially patients from our area.
Well, our doctors, our providers wrote letters. These were patients that they already knew that were their
Right.
patients.
Yeah, So that's what I'm saying. It's a difference, and I didn't have any information, and of course, no doctor in our area because they were brought here and put in the penal system here. Another question is about housing for males. Females, we have the shelters and things like that, and I think you mentioned that. How was that handled? Because it's hard for me to find housing for males.
This was one of Shirley's projects to get the hospital to fund some housing and working with a homeless advocacy, Virginia Supportive Housing, which is a homeless advocacy community-based group. So the hospital works with them. They have a lot of partners in the state, Virginia Supportive Housing does, which VCU is one of their partners. So they worked on it and got the funding, so they're funding, this is a one-year demonstration project. So they're funding the patients. This is, there's certain federal housing that once you get into, they all have waiting lists. Once you get into, you pay no more than 30% of your income. So if you're on disability, you pay no more than 30% of your income, so they pay that 30% to the facility where they're in beautifully re-renovated SRO housing.
And they were nice enough to do that for 5 of our, who we felt needed or most dire need of housing. So they did that for 5 of our patients, sickle cell patients, and 5
complex care
patients.
Which is another clinic, a different clinic.
Any limitations around it? Because one of my cases is a recent release.
I think tomorrow.
Yes.
They won't take them. We'll talk about it tomorrow.
I think we want to spend some time on it. It was a very unique, really unique opportunity, and we were very fortunate. And actually, both of the young men that are there are doing amazing in a very short period of time. So we're very proud of that.
Any other questions?
Anything else? All right. Well, you guys should spin the wheel while you're up there.
How do you spin the wheel?
Daniel? Daniel was out there napping.
Oh, yeah, what did you talk about your project stuff?
It is 508. Yep.
I don't think you do that.
Oh, I don't.
You click it with the thing.
All right. So, everybody's coming back tomorrow, right? Okay, great. So, whoever did not get a prize today, I can, we'll get one
This
tomorrow.
one.
Has it show up on there?
Oh, I see what you did. It's the end of it anyways, right?